Welcome to the deep dive. Today, we're taking a look at venography.
Right, that technique using contrast dye to, well, see inside your veins.
Exactly. And you might think, with all the fancy imaging we have now, why bother with venography?
Well,
But it's still incredibly useful.
oh, absolutely. And we've dived into the definitive source for this, Rutherford's vascular surgery and endovascular therapy. Top tier stuff.
We did. So you're getting the real deal here.
Yeah.
Our mission today,
Yeah.
to really get under the skin of venography
What it is, when it's used, how it actually works.
and why it's still so important for finding and fixing vein problems. Consider this your fast track, your shortcut to understanding it all. Ready?
Let's jump in. Okay, so fundamentally there are two main types, ascending and descending venography.
Right.
Ascending is the more common one. Think of it for finding clots, like DVT, deep vein thrombosis, usually down in the legs.
Okay, DBT detection. And descending.
Descending is more focused on checking the vein valves, seeing if they're leaky, basically. That's key in chronic venous insufficiency.
Gotcha. So ascending first, it sounds a bit like putting dye in a pipe to see where it's blocked. Is that fair?
That's a great analogy, actually. For lower leg DVT, yeah, they'll typically use a superficial vein in the foot.
A foot vein. Okay.
Yep, a tiny catheter goes in, and then the contrast dye. But here's the clever bit. They often use tourniquets
Tourniquets. Why is that?
to sort of dam things up temporarily. It forces the contrast into the deep veins, the ones they really need to see, instead of just filling up the surface veins.
Ah, okay. Directs the flow. Smart.
Mhm.
So descending, then checking the valves. How's that different?
That one's more direct. They need access right into the deep system, often up in the groin.
Okay.
Then they inject the contrast and watch where it goes, especially when you're tilted on a table. Sometimes they'll ask you to do a Valsalva maneuver.
Like bearing down?
Exactly. It ups the pressure, and they can see if those valves are holding tight or if blood's flowing backward where it shouldn't.
Interesting. Okay, let's talk DVT. Most people have probably heard of that. You said venography is still the gold standard. That surprised me a bit, given how much we hear about ultrasound.
It's true. It has been since the 70s. Back then, it was pretty much the only way to directly see a clot.
Right, before ultrasound was widespread.
Exactly. Now, don't get me wrong, duplex ultrasound is fantastic. It's accurate, non-invasive, usually easy to get. It's often the first choice. But venography still shines sometimes. Maybe the ultrasound's unclear, or maybe there's massive leg swelling making the ultrasound technically difficult. And especially for clots way down below the knee, those smaller infra-popliteal ones, venography can sometimes be, well, more sensitive there.
Right. Okay, so it has specific advantages still.
Mm-hmm.
You mentioned older techniques used a venous cut down. Sounds intense.
It's more invasive, yeah. Required a small surgical incision. Thankfully, that's largely gone.
Shoo.
Now it's almost always percutaneous injection, just a needle through the skin into a foot vein. Much better for the patient, safer, more comfortable.
Definitely sounds better. So walk me through it. What's the process like for someone getting an ascending venogram for DVT?
Okay. So you'd probably get a small catheter, like a 22 gauge, put in a vein on the top of your foot.
Right.
Then those tourniquets go on, ankle and maybe below the knee. Then comes the contrast, maybe 50 to 100 milliliters total, injected as you lie on this special X-ray table.
A fluoroscopy table.
That's the one. Real-time X-ray. They can tilt it, usually starting slightly head down, then leveling it out as a contrast moves up.
And they take pictures.
Yep, multiple X-ray images from different angles, at least 2 views around the lower leg and knee area to get a good look.
You also mentioned avoiding the saphenous vein near the ankle for access. Why is that specific point important?
Good catch. Yeah, the saphenous is a major superficial vein. If you inject there, the contrast might just zip up the superficial system and you won't get a good look at the deep veins, which is where the DVT usually is.
So the tourniquets help, but starting point matters too.
Exactly. And if someone's leg is really swollen, finding a good vein can be tough. Ultrasound guidance can actually help just find the vein for the venogram itself in those cases.
Okay, makes sense. So the images are taken. What exactly flags the DVT on the picture?
The classic sign is the tram track sign.
Tram track.
Yeah, imagine the contrast flowing around the clot. You see 2 thin lines of contrast, like train tracks, on either side of the dark filling defect, which is the clot itself.
Ah, I can picture that. Any other signs?
Sure, sometimes you might just see the contrast stop abruptly, or you might see a sort of curved edge where the contrast meets the top of the clot. That's called a meniscus sign.
Tram tracks, abrupt stops, meniscus. Okay. But is it always that clear cut? Seems like interpretation could be tricky.
It can be, you're right. Even experienced radiologists might disagree sometimes. The textbook mentions maybe up to 10% disagreement between observers.
Wow, 10%. That's not insignificant.
It's not. And that variability, plus the fact that it is invasive and uses radiation, is partly why ultrasound often gets the first look nowadays.
So if ultrasound is often step one, where does venography fit in most commonly for DVT now? Is it mainly for tricky cases or something else?
It's often about guiding treatment now. If a DVT is confirmed, and the plan is something more than just blood thinners.
Like clot busting.
Exactly, like thrombolysis, using drugs to dissolve the clot, or even mechanical thrombectomy, physically removing it.
Right.
Venography gives the doctors a really precise map, shows exactly where the clot is, how big it is. It's also key if they're thinking about angioplasty or putting in a stent later on, maybe for chronic scarring left after a clot.
Okay, so it's become more of a treatment planning tool in many DVT cases. Let's shift gears. Incompetent perforating veins, what are those again?
Okay, perforating veins. Think of them as little connector pipes between the superficial veins near your skin and the main deep veins in your legs.
Got it.
They have one-way valves, normally letting blood flow in towards the deep system. If those valves fail, become incompetent, blood flows backwards, refluxes into the superficial veins.
And that caused?
Problems. Increased pressure down there, varicose veins, skin changes, sometimes even those nasty venous ulcers. Finding those leaky perforators was important for planning surgery back in the day.
Venography was the way to find them.
It was, yes. Ascending venography, but with a twist. They'd put a really tight tourniquet around the ankle.
Why tight?
To try and force the contrast backwards through any leaky perforators, making them show up on the x-ray. They even used rulers on the skin to pinpoint their location relative to the ankle bone.
Clever. But I'm guessing ultrasound is taken over here too.
Largely, yes. Color flow duplex ultrasound is great for seeing flow direction and finding those incompetent perforators non-invasively.
Makes sense.
Though, interestingly, the book mentions a study comparing it to varicography, injecting dye directly into varicose veins, which found varicography might be better for certain perforators, like in the calf or mid-thigh. So nuances remain.
Always nuances. Okay, moving on. Venous aneurysms and malformations. Veins can get aneurysms, like arteries.
They can. It's less common than arterial aneurysms, but yeah. And the big worry is clots forming inside that bulging, weakened vein wall.
And those clots can break off.
Exactly. Potential for pulmonary embolism, especially with popliteal vein aneurysms, the ones behind the knee. The blood flow can be sluggish in there, perfect place for a clot to form and then travel. There was a study back in '93 showing this was a pretty significant risk.
Sounds serious if they find one.
Standard approach is usually immediate anticoagulation blood thinners and then planning. Surgery might even be recommended for asymptomatic ones to prevent trouble down the line.
And venography helps plan the surgery.
Precisely. It gives the surgeon a clear map of the aneurysm's size, shape, exact location before they go in to remove it and repair the vein.
Okay. And venous malformations, are they different?
Yeah, they're not quite the same. Malformations are more like tangles or abnormal collections of veins. Could be small, isolated lakes, or much more extensive, like in Klippel-Trenaunay syndrome.
What problems do they cause?
Can cause swelling, pain, sometimes reflux issues, or even clots. But actually, most people with malformations do okay with conservative treatment, like compression stockings. Surgery is less common and can be really complex, sometimes controversial for things like Klippel-Trenaunay.
So how does venography fit in with malformations?
Well, for aneurysms, it's often the standard ascending technique. For malformations, they might do what's called direct puncture varicography.
Injecting right into the malformation.
Exactly, often using ultrasound to guide the needle. Might even need anesthesia if it's complex. It helps define how extensive the malformation is, which veins are involved, crucial for planning any treatment.
And ultrasound helps here too.
Oh yeah, color flow duplex is great for popliteal aneurysms, especially looking for thrombus inside. And the book mentions something called closed system venography being useful for certain malformations too.
Okay, we've covered ascending quite a bit. Let's swing back to descending venography. You said it's for leaky valves and chronic venous insufficiency. When is it still the go-to?
Good question. While duplex ultrasound is usually the first screening test for reflux, descending venography is still seen as the, well, definitive test if they're seriously considering complex surgery like valve repair or even valve transplantation.
So for the really severe cases needing surgery.
Right. Duplex might show reflux, But descending venography gives that super detailed anatomical picture of exactly which valves are failing and how badly. That level of detail is critical for planning those big reconstructive surgeries.
It gives the surgical roadmap, essentially. How does that procedure work again?
Okay, so access is usually direct, often via the femoral vein on the opposite leg. Catheter goes up and over.
Right.
The patient stands, well, tilted upright on the table, maybe 40 to 60 degrees, weight on the leg not being examined.
Okay.
Then slow contrast injection into the iliac or femoral vein while they do that Valsalva maneuver bear down.
To stress the valves.
Exactly. And they watch how far down the leg the contrast flows backward or reflexes. They might do several injections to check different levels.
And how do they grade how bad the reflex is? Is there a scale?
There is, yeah. The Kistner and Herman classification. It goes from grade 0, which is normal, no reflux,
Okay.
all the way up to grade 4. That's severe reflux, where the contrast just rushes all the way down into the calf, often lighting up leaky perforators too.
So that grade helps decide who needs surgery.
It's a big factor. Patients with really severe reflux, say grade 3 or 4, and who have significant symptoms despite other treatments, they're the ones most likely considered for those complex valve surgeries. Descending venography provides that key evidence.
Makes sense. That classification is super helpful. Now, the outline mentions other specific areas too, like iliac vein assessment and looking at the inferior vena cava, IVC.
Right. IVC filter placement is a big one there. Those little filters catch clots traveling up from the legs.
Ah, yeah.
So venography helps map the IVC anatomy, check for clots already there, see the diameter, find the renal veins you have to place the filter below the renal veins. It also spots rare things like a duplicated IVC.
You need a clear picture before putting a filter in.
Absolutely. Access is usually femoral or jugular vein. It's also important for planning IVC filter retrieval checking for a trapped clot, filter tilt, or if it's embedded in the wall.
Okay. What about treating narrowing in those big veins, iliocaval stenosis, like May-Thurner?
Yeah, May-Thurner is that specific compression of the left iliac vein by the right iliac artery. Venography is key when treating these narrowings, often with angioplasty and stents now.
So you need to see the blockage clearly.
Exactly. Access might be from the mid-thigh or even behind the knee, often ultrasound guided to get a good view. Venography shows the narrowing, maybe pancaking where the vein is flattened, or collateral veins bypassing the blockage.
Pancaking.
Yeah, flattened appearance. But here's where IVUS often comes in.
Intravascular ultrasound.
Right, tiny ultrasound probe inside the vein, gives a cross-section view, really helps measure the narrowing accurately and size the stent correctly. Venography gives the map, IVUS gives the precise measurements.
Cool combination. Okay. Pelvic congestion syndrome. Venography for pelvic pain.
It can be, yes. This syndrome involves chronic pelvic pain, often linked to leaky ovarian veins or pelvic varicose veins.
So venography can find the source.
It can help. Selective catheterization, usually of the ovarian veins, injecting contrast while the patient is tilted head down and doing a Valsalva. They look for dilated veins, contrast hanging around too long, filling of pelvic varices.
Specific criteria then.
Yep. Things like ovarian vein diameter over 6 millimeter, contrast retention 20 seconds. Can also check for nutcracker syndrome, compression of the left renal vein by measuring pressure differences.
Okay, interesting. Briefly, what about varicocele? Those enlarged veins in the scrotum.
Venography is still sometimes called the gold standard there, especially if ultrasound is unclear or they're planning embolization treatment.
Embolization.
Yeah, blocking off the abnormal veins. Venography involves selectively catheterizing the testicular vein, usually via the femoral vein, looking for backward flow reflux, especially with Valsalva. The findings directly guide where to place coils or agents to stop that reflux.
And renal venography for the kidney veins.
Used to check renal vein anatomy, look for clots, renal vein thrombosis, or see if a tumor is invading the vein. Again, finding filling defects indicating thrombus is key.
Okay, lots of specific uses. What about the upper body? Arms, chest.
Definitely. Upper extremity venography is crucial for arm swelling, maybe from a clot, or compression like thoracic outlet syndrome, or superior vena cava SVC obstruction.
Seen more of that with catheters and pacemakers.
We are, yeah. Central venous occlusion is on the rise. The technique involves injecting contrast in an arm vein, sometimes positioning the arm differently to check for compression.
Like in thoracic outlet syndrome.
Exactly. You might see narrowing near the collarbone when the arm is raised. For clots, you see non-filling and collateral veins. For SVC obstruction, often caused by malignancy, venography clearly shows the blockage and the bypass collaterals. Sometimes they inject contrast in both arms at once.
It seems venography really covers the whole venous system when needed, but it is invasive. What are the main downsides or risks we should mention?
Good point. Always important. Limitations are it's invasive, involves radiation, interpretation isn't always 100% consistent, and getting vein access can be hard, especially with lots of swelling. Sometimes the filling isn't perfect.
And risks.
Mostly minor, pain, bruising, maybe infection at the site. Allergic reaction to the contrast is possible. More serious, but rarer, things include thrombolysis, vein inflammation causing a new DVT, bleeding, or even pulmonary embolism. Very rarely a temporary heart rhythm issue during pulmonary arteriography.
So definitely not risk-free. Benefits versus risks, always. Looking ahead then, what's the future hold for venography? Is it fading away?
It's an interesting question. With CT and MR venography getting better and better, its role in pure diagnosis might shrink for some things.
Makes sense.
But it's still the reference standard, the benchmark others are measured against. And crucially, as we do more and more endovascular treatments, fixing veins from the inside with catheters, stents, etc., venography's role as a guidance tool is actually increasing.
So it's essential for performing those minimally invasive procedures.
Absolutely. And combining it with IVUS enhances it even more for diagnosis and guiding treatment. So while maybe not the first test ordered as often, knowing how to do and interpret venography is still a vital skill for vascular specialists.
Right. So pulling it all together then, venography, maybe not the newest kid on the block, but still a really crucial tool, especially for DVT diagnosis in certain cases, and absolutely vital for guiding many of those modern, minimally invasive vein treatments.
Exactly. Even with all the high-tech, non-invasive imaging, sometimes you just need that direct, contrast-enhanced look. It still holds its own, especially for complex cases and treatment planning.
It really highlights that balance in medicine, doesn't it? Between the detailed view from an invasive test and the convenience of non-invasive ones.
Definitely. It's about choosing the right tool for the right job, for the right patient.
So here's a final thought for you, our listener. As these amazing non-invasive technologies keep getting better and faster, how do you see the role of these established gold standard invasive procedures, like venography, continuing to shift and adapt in the years to come? Something to ponder. Thanks for joining us for this deep dive.